Hi, I'm Patty Cason. I'm a family nurse practitioner with a specialty in sexual and reproductive health, and I'm going to talk with you today about bleeding with progestin-only contraceptives. Here are my disclosures. Here are our learning objectives. Interestingly, the mechanism by which progestin can cause unfavorable bleeding is actually not fully understood. What we do know is that it will be different depending on the dose or the route of administration, systemic or local, for example. We also know that initially progestin will take a little bit of time to thin the endometrium. And during that time when that endometrium is thinning, you may see some bleeding that's really unpredictable, and it could go on for a while. It could be absolutely fine, but it also could be a lot of kind of frequent and prolonged bleeding. What we like to call bleeding that'll go on for a while and can get really annoying. It's my patient-centered language. And then we know that with time, once the endometrium is fully thinned, you do tend to see a more predictable and quote better bleeding profile, meaning less bleeding. So as I said, type and dose, how it's delivered, and how long you're using it are all factors in what the bleeding pattern is going to be like. But I also have to say that the type of progestin itself will actually also have different types of patterns. So for example, Levonorgestrel is particularly good at controlling the endometrium, so it may have a somewhat better bleeding profile. That's why it's used for a lot of progestin-only methods. And they do change over time. So we talked about this in another one of the short webinars that you've seen, hopefully, which is about the effect on the ovary and the effect on the endometrium of progestin. So I'm going to quickly go through this again, but with a minimal dose of progestin that you would see in a Levonorgestrel IUD, for example, you're going to have you're not going to have suppression of ovulation. You will, with all progestin-only methods that have just progestin in them, all of them are going to cause thickening of the cervical mucus. So will any method that has combined hormonal contraceptive action also. So anything with progestin in it, whether it's progestin only or combined hormonal, will create thick cervical mucus. Follicular growth will be seen whenever there's non-ovulation, obviously. But also if there's only sometimes ovulation suppression, you'll see follicular growth like you would with a low dose of progestin-only pill, like the norethindrone progestin-only pill. When we get up to a mid-potency implant, the etonogestrel implant, or the drospirenone progestin-only pill, or combined hormonal contraceptives, the progestin in there, those all are meant to reliably suppress ovulation. And obviously I say are meant to because there's some amount of user component here. So if the person is not fully adherent, there could be some disruption of ovulation suppression. But in general, these suppress ovulation. They don't necessarily suppress all follicular activity. So you may still see some cysts growing with a mid amount of progestin. I don't want to say mid-potency because it could be the dose. And then when you get to the really high doses like you do with DMPA, you're going to have really reliable ovarian suppression, ovulation suppression, as well as some ovarian suppression. So it will actually shut down quite a bit of ovary function. So you may see a hypoestrogenic state from that and not likely to see any follicles developing. When it comes to the cervix, all progestins will both thicken cervical mucus, as I said, and also thin the endometrium, which is a very healthy state for the endometrium to be in, prevents endometrial cancer. A critically important part of helping your patients to be really happy with their contraceptive method and to use it successfully is to be respectful and understanding of the wide variety of people's attitudes about bleeding. People have different preferences. People have different understandings about the safety and the meaning of bleeding. Sometimes that's based on information that's accurate, sometimes misinformation. Sometimes it's purely emotional. There's fear, they've seen something happen to somebody else and they are really reticent because of something that may not have anything whatsoever to do with the science. Some people can tolerate bleeding that goes on for much longer than other people can tolerate. Some people have meaning that they imbue with their bleeding that wouldn't occur to others. I could go on, but it's very important that you understand what your individual patient's perception about their own bleeding is, and that isn't something you can predict unless you ask. So, when thinking about methods that could potentially cause amenorrhea, and I want to say when we talk about unfavorable bleeding, we're mostly talking about they're having too much. Could also be that somebody's unfavorable bleeding pattern is that they don't want amenorrhea. But in general, when we talk about treating unfavorable bleeding, it's because there's too much of it. If you get to a situation where somebody has amenorrhea that they don't want, you can probably, if the person's not contraindicated to use estrogen, you can probably fix that by giving them estrogen and then having a hormone-free interval without that estrogen. And you can probably create bleeding that way. So if somebody has some concern about amenorrhea, and you've said to them, many people who use this don't get their period, how would it be for you if you didn't get your period while you're using this? And the person says, oh, no, that's not for me. What we're going to say, I'm going to say do's and don'ts. So don't assume that you know why. Don't assume you know that that person is afraid that if they don't get a period, they won't know they're not pregnant. Don't assume that you think that they think that it's not healthy. Don't ask why, and certainly don't say, why on earth would you want your period? But you all know not. You know not to do that. but saying why might presume that they ought to want amenorrhea. And of course, you don't use the word amenorrhea. You would say you won't get your period. So you would want to then, however, ask what's concerning to you about not getting your period. So you ask somebody, you say, many people using this don't get their period. How would it be for you if you didn't get your period while you're using this? And they say, oh, no. And you would hopefully come back and respectfully, with an honest desire to know, say, what is it that's concerning to you about not getting your period? I hear that all the time. Can you tell me more about that? So let's run through some of the most common things that you might hear. I'd always worry I might be pregnant. So you would start with something positive. I can see it's really important to you not to get pregnant until you're ready. Or, many of my patients say they like to get their period every month because they feel like it lets them know that they aren't pregnant. So let's run through a couple of these scenarios. Somebody might say to you, I'd always worry that I might be pregnant. Or they may say, how would I know I wasn't pregnant? Which would be great because then you can answer that question. But they may just express the concern. I'd always worry I might be pregnant. You'd want to start with something positive before actually clarifying any information. This is a generalizable principle for counseling with contraception, is find something to agree with, a kernel of truth, or something to empathize with. If the person said, I'd be afraid every month that I'd be pregnant, you can say, wow, I could see how that would really feel terrible to think you were to be afraid to be pregnant every month. So start with something good, positive, affirming, and then give the piece of information the person needs. So I think the person needs the piece of information that getting your period doesn't tell you you're not pregnant. So I might say, interestingly, many people still bleed at the beginning of a pregnancy. Or I might say, it's so funny, I hear that all the time, and I can completely see why you'd think that. Today in our office, as pretty much every day when we work, we see people coming in thinking that they're having their period when in fact they're pregnant. So I wish I could tell you that getting your period tells you you're not pregnant, but so you could at that point use motivational interviewing and say, have you ever tried anything else besides getting your period to reassure you you're not pregnant? They might say, yeah, I got a pregnancy test. Seems obvious. But then you could say, pregnancy tests are really, really very reliable, and they're not expensive at all at the 99-cent store. What about if the person says, my mom says it's not healthy not to get my period? Okay, so find a kernel of truth in that. Is this person's mother right? Yes, the person's mother's right. Your mother's completely right, which is always a good idea to tell them your mother's right. As a mother and a grandmother, totally think that's a good way to go. Your mother's completely right. When you're not on hormonal contraceptives, it's important to get a monthly period, and it's really great that you know that. I'm so glad you know when you're not using birth control with hormones in it and you miss your period, you need to come in and see what's up. Now, hopefully the person will then say, well, what about if I am using birth control that has hormones? If somebody asks you the question, they're going to be much more likely to listen to and understand the response. But if you didn't have that lucky question asked of you, then you might just volunteer. Interestingly, if someone uses birth control that has hormones in it, the hormones keep their uterus really thin and healthy. And if you're the lining of a uterus, thin is healthy. You could even say it prevents cancer of the uterus. And then, very important for this particular thing, and again, a generalizable principle, whenever possible, use a visual aid or a tactile aid or both. Holding a little IUD if they're going to have that placed in their body, seeing an anatomy picture like this one. So I would then take this anatomy picture and look at this endometrium here and point to it, and I would say, this is the lining of the uterus. This is the uterus. It's where, if you have a baby, this is where the baby would grow, or if the person already had a baby, when you had a child, this is where the baby grew. And then show the lining, outline it with your finger, and say, this gets really thin when you use birth control that has hormones in it. And that's extremely healthy, and it actually even prevents cancer of the uterus. So let's think about how the various methods change the way your periods come. I think instead of saying menstrual changes or menstrual bleeding changes, I think changes the way your period comes is probably patient-centered language that people will understand what that means. So implant, bleeding patterns unpredictable. And then in each 90-day time period studied, about over 50% of users had either no bleeding whatsoever or occasional light bleeding or occasional spotting, but much less than they would if they were menstruating regularly. So you're going to give a piece of information about how the bleeding pattern would be, and then you're going to say, how would it be for you if you didn't get your period while you're using the implant? Or you might have said, the bleeding pattern is unpredictable. I won't be able to tell you exactly what your bleeding would be like, but usually most people are happy with it. How would it be for you if you couldn't predict? So also about 1 in every 4 or 5 users at some time periods. So if you take a 90-day time period, which is how these products have pretty much all been studied, in a given 90-day time period, about 1 in 4 or 1 in 5 users will have a period of time where they have frequent or prolonged bleeding. I don't like using the term frequent or prolonged with patients. I think it's much clearer if I just say bleeding that can go on for a really long time and get super annoying, or something like that, so that it's, patient-centered language. And then I would follow that with a question. Have you ever had bleeding like that? Or if they have told you they did, how did you manage it, or how would you manage it if you did? So with the implant, again, it does tend to get better with time. So if the initial bleeding pattern is favorable, it will tend to stay that way. And if the initial bleeding pattern is not as favorable, it will tend to get better with time. Interestingly, a lower serum metanogestrel level is seen with people that are, for example, obese, and people with a lower serum metanogestrel level tend to have better bleeding patterns, actually. I just want to reassure that somebody with a higher BMI is not at increased risk of pregnancy with a metanogestrel implant. So we know that about 20% of people will discontinue. Actually, interestingly, this is for all long-acting reversible methods. So implant and all of the IUDs all have about a 20% discontinuation rate at a year. Just a little factoid to share. But for the implant, about half of those are because they didn't like their bleeding pattern, and it was probably the frequent and prolonged. So in general, 80% of those with favorable and 40% of those with unfavorable bleeding patterns, the next 90-day cycle will have favorable bleeding patterns. The hormonal IUD changes the way your periods come. Also, I always like to say this is very likely to change the way your periods come. It almost always does. Most cycles, when somebody's using a hormonal IUD, are still ovulatory, so cyclic bleeding is an actual period. It's not just bleeding from, odd progestin effect. It's actually a period. Generally, menses become increasingly light with time, and then at a year, somewhere between 20 and 80% of people, and over the next year or two, will have amenorrhea. And I say that range because it's strict. Amenorrhea is 20%, so not one drop of blood in the last 90 days, that's 20%. But somebody who says, I don't get my period, that's at least 50%. And people who have seen enough change in the way their bleeding is coming to really think that they're not any longer, a menstruator in the way that they were, they may refer to it as not getting their period as well. But definitely after a couple of years, you're starting to see the majority of people are not having their period. So we generally have told people that it's in the sort of 4 to 6 month range when their bleeding starts to get better. It tends actually to happen a little sooner, as it turns out. We've got some newer data. And so in the first 3 months, usually about 35, 36 days of bleeding. So that's including spotting. So if you include spotting, bleeding, and light bleeding, all types of anything coming out of the vagina that is blood, that's 35, 36 days in a given 90-day period, right? So that's more than 10 days a month. But in the next 3-month period, that goes down to 19 days. And so it's a pretty big shift. And then it continues to get less and less with time. So if you're just looking at only bleeding days or only spotting days, they also continue to decrease for the entire year. But this is important information, is that first 3-month time period is really when you see the majority of the unfavorable bleeding. So if the person is having unfavorable bleeding in the first 3 months, which as you're going to see here is about 67% of people have irregular bleeding when they first start with the hormonal IUD, by the 9 to 12 month period, that's down to under 20%. People are generally, as probably everybody knows, pretty happy with the bleeding profile that they get with the hormonal IUDs once it's past that first 3-4 months. So the smaller IUDs, as I said, they don't inhibit ovulation at all, and maybe once in a very long while with the 19.5, but the 13.5 really does not inhibit ovulation, and really functionally neither does the 19.5. But it also then brings about less amenorrhea. So the person's more likely to have irregular bleeding in the beginning, more likely to have spotting and frequent bleeding, and more likely to have a regular cyclic bleed as time progresses. So more irregular bleeding up front, more likely to have a bleed that is cyclic, which is actually a period, because they're still ovulating. So they ovulate and 2 weeks later they would have a period, but it would be very light and lighter with time. And with the second IUD, and these data are for the 52 milligrams, so either a Liletta or Mirena, much less bleeding in that first 3-month adjustment period because the endometrium's already been thinned. That's what we believe to be the mechanism by which the second IUD is better in terms of its bleeding profile than the first. So the shot, probably everybody knows, really a lot of amenorrhea with the shot. Most people do not get their period while they're using it, and often that'll start in the first shot, sometimes within the first 2 shots or even longer, but generally within the first 2 shots people have stopped getting their period. They may have 7 or more days of frequent bleeding or prolonged bleeding, and that does tend to get much better with the second and third injections. The problem, as far as I see it, with the DMPA is that it has not got immediate return to fertility. Every other birth control method, the minute you stop it, your ability to get pregnant goes back to whatever's normal for you immediately. Not so with this one. So it could take as long as 1.5 years, 2 years for the person to regain fertility. It may take that long for them to get their period back as well. Not usually that long, but it's not unheard of for it to be a really long time. I like to prepare my patients that it's going to be at least several months, probably. But as with everything, if the person wants to have return to fertility, they won't have it. And if they are desperately interested in preventing pregnancy, they'll be the one person who's going to ovulate right after stopping their last shot. I'm kidding, of course. So how do progestin-only pills change the way the periods come? They're different for the different ones. So the drospirenone is going to have a scheduled bleed, a 4-day hormone-free interval. So that is something that you can use as a way to control bleeding. The norethindrone product is a 1 active pill every single day, and it's generally fairly good bleeding, meaning that generally what you get is bleeding once a month or amenorrhea, and that bleeding once a month is often a menses because it isn't reliably suppressing ovulation. So you could get frequent bleeding, you could get prolonged bleeding. It does tend to get better with time, but the bleeding is likely to be actually a menses. So letting somebody know beforehand what is likely to be the bleeding pattern and asking them very clearly how that would be for them. That's extremely important. And letting them integrate the information about what the bleeding pattern is likely to be like or what the options are for how it might be. Lets them try it on, lets them integrate the information so they can actually remember it. So that when they're having a concern, once they're using the product, they will be able to remember that you already told them about this. They already knew that there was management available potentially if that's what they want. They have already tried it on for size and they remember that this is something that happens and it's not unusual. So they hopefully also takes the fear out of it. So I don't think we need to rush in about reassurance. Yes, it's true that this is probably absolutely fine and it's not dangerous. It doesn't indicate reduced effectiveness, but you should find out exactly what the person's real concern is first before rushing in with reassurance. So find out, are they concerned that it's not effective? Then you can let them know that it is. Are they concerned that they may have an infection? Are they concerned that they're that this is going to mean that they have cancer? Does this mean that they are never going to have sex again? And that's their big concern. Are they fighting with their partner? You know, what is really bothering them about it so that you can address their concern individually? And that's really an important step in addressing someone's concerns. You want to make sure you find out if they're on any concomitant medication that could cause the progestin in their method to become lower systemic amount and potentially less effective. So that's an important thing to find out. And then other things that could possibly be causing irregular bleeding should be ruled out. You don't want to just always reassure just because someone's on a progestin-only method. You want to first make sure you've ruled out anything that's significant. And the way you would do that is you think about other symptoms. So are they having pain, discharge, postcoital bleeding, abdominal symptoms? And then I'm not saying everybody with unfavorable bleeding should have a pregnancy test, a speculum. I'm not saying that all these things should be done for every patient, but you want to think about the possibilities of what might be going on and then test accordingly as you think appropriate. And these are the tests that you want to think about. Certainly if somebody's got an IUD with new bleeding, you do want to at least take a look and make sure their string is still there and do a bimanual exam. It's never a bad idea to rule out pregnancy. So in general, I like to think about ruling out things that are really serious if you're having unfavorable bleeding. Those things generally fall into these three buckets. Is the person pregnant, ectopic, or just pregnancy and they're bleeding? Is there an infection, any kind of upper genital tract infection? Chlamydia, gonorrhea, PID, these things can cause bleeding, obviously. And in fact, for somebody that's a long-term user of progestin-only method, if they develop new bleeding and they're young, infection is absolutely at the top of the list in terms of the differential. And then malignancy. Do they have cervical cancer, endometrial cancer, signs or symptoms of anything like that? So those are the things that you really want to be able to rule out and not miss. For any progestin-only method, NSAIDs are a really good place to start as first-line therapy for unfavorable bleeding. It's been studied with pretty much all the methods and been shown to be potentially effective. We don't have a lot of data for any management for unfavorable bleeding for anything with birth control. Just have to put that up front. But we do have, what data we have? We have for NSAIDs. So naproxen sodium is a really good choice. It's very good on the endometrium and it's only twice a day dosing. It's available as a prescription or over the counter as Aleve or generic Aleve. So estrogen is another thing that has a lot of data for it. Again, relatively a lot of data. There's not a lot of data for anything. But it's been shown to be effective for the implant, progestin-only pills, and DMPA, not actually for the Levonorgestrel IUDs. But the estrogen is in there to build and support an endometrium, so it actually gives the body something to be able to shed in a controlled way. And your options for doing that would be a combined oral contraceptive, monophasic, best, because then you don't have the confusing several different phases. Vaginal ring works, estradiol or conjugated equine estrogen would work. This is the dose range, probably more successful with the higher dose range, so 2 milligrams of estradiol or 1.25 of conjugated equine estrogen. There really isn't any reason to think about limiting the length of time somebody uses these. They could use them for the entire length of time they're using the method of birth control. You could try it for a 2 or 3 week period and then see how they do. You could try it for a 2 or 3 week period and then take it away and explain to them that they probably are going to have some bleeding when the estrogen is stopped, and that's what's expected. But hopefully at that point it will sort of reset and things will be more favorable from then on. But if they're not, there's nothing saying they couldn't continue to do this throughout the time that they're using the method. It's much better for somebody to be using a highly effective method that has potential bleeding issues that are controlled with a low dose birth control pill or a low dose of estrogen in another format like this, than it is for them to use a less effective method of birth control. So with the Levonorgestrel IUD, we're a little bit more hamstrung because we don't have any of those estrogen products that have been shown to help. You could certainly try them, but there was one study that showed that it didn't help with that initial bleeding in the first 3 months. But NSAIDs have been shown to work. The other thing about the Levonorgestrel IUDs, let me say, is that they do have a fairly reliable, predictable bleeding pattern, which does tend to get better with time. So the nice thing we have about the unfavorable bleeding with the Levonorgestrel IUDs is that we can tell our patients that it's very likely that after 3-4 months, this is really going to simmer down and you're just going to have light periods that tend to get lighter and lighter with time and then eventually probably go away altogether. So other treatments, and I don't want to discourage trying these, but I would say the data are either not strong or in most cases here, they're not practical is the problem. So doxycycline has been shown to work, but only pretty much, and not always shown to work, but pretty much only during the time when somebody's taking it. There have been some studies looking at really low dose, but most of the studies are on 100 milligrams twice a day for 5 to 7 days. If you think that the person has possibly endometritis that's contributing to the bleeding, this might be a reasonable thing to think about. Mifepristone has been shown to work, but it's very hard to obtain. It's restricted as a abortifacient in the United States, and the dose that you would use that's been looked at in clinical trials isn't available. Tamoxifen does have promising data. I have taken tamoxifen as a patient, and I found it to have a lot of side effects. So for me, I have a bias. I'm just going to put that right up front. I have a hard time getting my head around giving somebody tamoxifen for a long period of time for unfavorable bleeding. But that's just my prejudice. Ulipristal acetate also has been shown to be effective, and it is, they had to stop one recent trial early because they couldn't get enough product. So it's not really it's not easy to get in the dosages and for as long as you would take it. And tranexamic acid has also been shown to be helpful, but it's really a little burdensome because you have to take it 3 or 4 times a day. The dose range is wide, somewhere 250 twice a day, ranging all the way up to 1300 TID. Also, there is a DVT risk similar to estrogen associated with using tranexamic acid. So I love the idea of trying a progestin-only pill. It's very, very safe, and it's not going to hurt to add more progestin to somebody's progestin, and it may just hasten the thinning of the endometrium, and there's a lot of anecdotal report that it works. I have not, for the life of me, found one shred of data. Who would have thought, this is our last slide, but I just have to say I ran into this, that people with smaller uterine dimensions actually have less bleeding with IUD use than people with larger uteri, and less pain. So if you're worried about not wanting to use an IUD with somebody who has not had a child and therefore has a smaller uterus, let this information reassure you. Thank you.